Hi there. You walk into a home health visit and the patient says, I don't know what half of these new pills are for, and I think I've been taking them wrong. Now you're thinking, what do I even chart to show that this is a skilled nursing visit? Well, instead of guessing, use this framework: the condition, the risk, skilled action, response, continued need. And let's break it down here. Imagine a patient recently discharged from the hospital with 3 new medications added: a new hypertensive medicine, a new anticoagulant, and a new diuretic. During your visit, you discover that the patient cannot correctly identify medication purposes. Patient is unsure of dosing schedule, missed doses reported, confusion between old and new medicines, and no clear system for organizing meds. Most nurses document medication reconciliation completed, education provided. But Medicare is looking for something a little bit deeper. Why did this require a skilled nurse today? Well, step 1, condition. Ask yourself, what is the most significant issue today? Well, in this case, it's the medication regime confusion. Recent medication changes, missed doses, incorrect administration. This is not just education needed. This is high-risk medication management instability. So step number 2 is the risk. What could go wrong if this continues? Well, this patient is at risk for stroke if the anticoagulant is missed, hypotension or falls with the new hypertensive, fluid overload or dehydration with the diuretic mismanagement, and hospital readmission or serious medication adverse events. Now the situation becomes clinically serious. Skilled action. Why was a nurse required? Well, a family member, they can hand a pill to a patient from a bottle. A nurse can perform full medication reconciliation, identify discrepancies between discharge list and the home list, evaluate patient understanding of each of the medications, and assess for adverse effects or contraindications. Prioritize medication safety based on clinical judgment, and communicate with the doctor or the pharmacy if needed. That is skilled nursing. Today's skilled action may include full medication review completed, identification of medication errors or omissions, and teaching on purpose, the dosing, the timing of the new medications, and develop of a simplified medication schedule. Reinforce of high-risk medication safety, such as the anticoagulant precautions, and doctor notification if there's discrepancies or concerns. Step number 4 is the response. What happened because of your intervention? Maybe the patient correctly repeats dosing schedule after teaching, demonstrates improved understanding of the anticoagulant safety, and still requires reinforcement due to cognitive or memory limitations. Document the response. This shows the effectiveness of the skilled intervention. And then step number 5, continued need. Why are future skilled nurses' visits still necessary? Well, the patient continues to demonstrate medication regime complexity, knowledge deficits, high-risk medication requiring monitoring, and ongoing need for reinforcement and assessment. Now that supports continued skilled nursing services. So, putting it all together, now converted into a clinical narrative. The patient recently discharged with multiple new medications, including antihypertensives, anticoagulants, and diuretics. Significant medication regime confusion noted during the visit. Patient unable to accurately identify medication purposes or dosing schedule and reports missed doses since discharge. Skilled medication reconciliation performed with comparison of discharge instructions and in-home medication supply. Education provided regarding purpose, the dose schedule, and safety considerations for each medication, with emphasis on high-risk anticoagulant precautions, and potential adverse effects. Medication administration schedule simplified to improve adherence. Patient able to demonstrate partial understanding but continues to require reinforcement due to ongoing confusion with regime complexity. Patient notified of medication discrepancies as appropriate, and skilled nursing visits required due to high-risk medication regime, knowledge deficits, and the risk of adverse drug events and hospital readmission possibilities. So this is what the Medicare reviewer perspective looks like. The condition, well, it's post-discharge polypharmacy with medication confusion. The risk, adverse drug events, fall, stroke, hospitalization. Skilled need, well, the clinical medication reconciliation, assessment, interpretation, and teaching. And the skilled intervention, medication management education, safety, interventions, and coordination with the doctor. And the continued need, well, the regime remains complex and unsafe without skilled oversight. So in closing, the next time you see medication confusion in home health, don't document it as teaching provided, but ask yourself this: what is the condition? What is the risk? Why was a nurse needed? And what skilled action occurred? And why are future visits still necessary? When you think this way, your documentation shifts from just task-based charting to Medicare defensible clinical reasoning that clearly shows skilled nursing necessity. I hope this has been a benefit to you. Consider subscribing, and there's also some resources on the channel description. Thank you and have a good day.